So, good evening, everyone. I am Dr. Yogesh from Medical Affairs team of Sun Pharma, and it gives me great pleasure to extend to you a very warm welcome on behalf of Sun Pharma for today's webinar. In line with our mission statement that is reaching people and touching lives, Sun Pharma recently launched Sankalp initiative, and all of you must be part of this initiative. So all of you must be receiving all the updates and the patient videos as well as the CME updates from Sankalp initiative. The main agenda of Sankalp initiative is to help you to be the first and be the best in dealing with the patients with lifestyle diseases, which includes diabetes, hypertension, GI diseases, respiratory diseases, to be specific, asthma. So all these are covered under Sankalp initiative. And it gives me great pleasure to introduce to you an online platform that is a website of My Sankalp under Sankalp initiative, that is mysankalp.com. It will be your smart companion, which will provide you a simple, medically accurate research based content in the form of newsletter, webinars, clinical education videos, patient education videos, as well as clinical updates, which will definitely help you to keep your knowledge updated and also help in patient management. And it will also provide you a virtual assistance as a part of Sankalp initiative. So there were webinars which were conducted previously, and now as a promise, today we have come up with a webinar which will be done for GI disorder. The topic of today's webinar will be heartburn and heart attack. All of you will agree with me that after pandemic, what we faced, and after lockdown and whatever changes we seen, recently there is increase in acute myocardial infarction risk in young population. This may be attributed to the COVID virus, also the lifestyle changes what happened because of the COVID pandemic. One more thing is that in GI disorder, GERD is again very rampantly increasing, attributed to our lifestyle changes and dietary modifications what we are going through. The GERD mainly present as a heartburn, which is basically chest pain, which feels under your breastbone, which is more commonly mistaken for a heart attack, and it can happen vice versa also. So, as a need of an hour, today's topic was identified, and I'm very fortunate to introduce our guest speaker, Dr. Prem Kapoor, who will be speaking on this topic today. Dr. Prem Kapoor is a well-known figure in the field of medicine, and he brings with him a vast clinical experience. He is alumni of Maulana Azad Medical College, Delhi University. He did his senior residency from the year 1982 to 1985 from GB Pant Hospital, New Delhi. He brings with him more than 35 years of clinical experience. He has been a DNB teacher for family medicine at Hamdard University Hospital or HH Hospital. He, from the year 2003 to 2006, he worked as assistant professor in the Hamdard Institute of Medical Science and Research from year 2012 till 2016. Then he continued as associate professor, and finally he took the responsibility as a professor and HOD from year 2019 to 2021. As a part of his research contribution, he has over 50 publications in national and international journals. Also, he has written chapters in various books and monograms. He has also guided 7 postdoctorate students in various faculties of Hamdard University, New Delhi. He is recipient of the award for Best Paper Presentation in Epicon held at Gurgaon, Haryana, India in 2015. Gastroenterology, hepatology, and tropical medicine are few of his area of interest. It is our great pleasure to have you here, sir. And now I will hand it over to you for further proceedings. Over to you, sir.
Thank you, Dr. Yogesh.
Yeah. You can use.
I've been assigned a topic to discuss with my fellow colleagues, which is heartburn and heart attacks. So we are going to take up this topic and discuss it threadbare as to, because it's a very common condition that we see in our day-to-day practice. And I think all of you would agree that uh, when you're sitting in your clinic or you are in emergency department of a hospital, many times patient would come and say कि साहब छाती में जलन हो रहा. Now this छाती में jalan could be anything from a simple gastritis, reflux esophagitis to a acute myocardial infarction. And since the severity and the prognosis of the conditions differ so vastly, we need to be very aware and be alert not to miss anything that is serious that is happening in the patient. And let us see how we can differentiate between say reflux esophagitis or GERD, it is called, which is gastroesophageal reflux disease, or a sinister condition like a acute myocardial infarction or a acute coronary syndrome. So I'll be discussing this topic under various headings, which can you see the slides?
Yes, sir.
You can?
Yeah. Can you?
Okay.
Yeah.
So the scope of my presentation would be in the form of following subheads. I'll first be introducing to you the concept of the chest pain as we know it. Then we will go into what are the GI disorders which can give rise to this chest pain. Then we'll talk about differentiating this chest pain of cardiac origin versus the heartburn that we see in gastrointestinal diseases. Then we talk a little bit about acute myocardial infarction. How do you work up the patient and how do you do the initial management? Because this also comes very handy once you are in the ED of a hospital, emergency department of a hospital. And then we talk of management of patients with the GERD, which is gastroesophageal reflux diseases. So let's start with the chest pain. You see, as I told you, chest pain is a very common complaint in primary care setting and also in emergency department of any hospital. And the figures tell us that about 20 to 40% of the population will visit their GPs for chest pain during their lifetime. And GI disorders, including GERD, is the fifth most frequent cause of chest pain in primary care. In fact, this also stems from the figure of 20% of incidence of GERD in the US. So it's a pretty common condition and then needs to be differentiated from something very serious as acute coronary syndrome. Now, these are some of the causes of chest pain that you will see in your day-to-day practice. You see, there could be cardiac, pulmonary, gastrointestinal, musculoskeletal, or psychogenic causes. Out of cardiac causes, the most important remains acute coronary syndrome. See, all coronary artery disease is divided as a angina or a stable angina, and then acute coronary syndrome, which would include unstable angina, a ST elevation MI, and a non-ST elevation MI. This is the main differential diagnosis which we are going to discuss in today's talk. Then we can have conditions like aortic dissection and aortic aneurysm as causes of chest pain. There could be valvular causes like aortic stenosis, mitral valve prolapse, which can sometimes in young females present with recurrent chest pain, especially on exertion. And then in the heart, you may have pericarditis, myocarditis causing chest pain, and an interesting condition called Tekusovo cardiomyopathy. This is a disease which was first described in young middle-aged females, where just because of a severe stress, you would have a chest pain and symptoms very much like acute myocardial infarction, but it was just because of increased release of adrenal hormones that you will the patient, especially females, would develop hypertension and dilatation of the apex and the middle part of the heart where the base remains the same, and they have sutures. And if you leave these patients alone, they may improve on their own or give beta blockers. So very interesting anecdotal condition called Tekusobo cardiomyopathy, and then cardiac tamponade, where you suddenly have a massive pericardial effusion leading to zero output from the heart. Then we can have pulmonary causes causing this chest pain. Pneumothorax and viral pruritus are the ones which can present all of a sudden, as is pulmonary embolism. So vascular causes, pulmonary vascular causes, pulmonary embolism. A very, very important differential diagnosis of severe acute onset chest pain in a hospital setting. Then you can have some other causes from the lungs or the airways, like pneumonia, bronchospasm caused by acute bronchitis, COPD, bronchial asthma, and then you may have diaphragmatic hernia, what is known as tossing pleuroc syndrome, which is herniation of the diaphragm on the right side. Then biliary causes like cholangitis, cholecystitis, and choledocholithiasis, which again can give rise to sometimes pain in the right lower chest. Then esophageal causes, the most important differential diagnosis of acute coronary syndrome, which is esophagitis, esophageal spasm, eclasia cardia, gastrointestinal reflux, gastroesophageal reflux disease, and esophageal impaction by foreign bodies. There could be peptic ulcer disease, which may sometimes present with pain in the lower chest and epigastrium, and pancreatitis. Again, the pain may be referred to the left lower chest as well. Musculoskeletal causes, we may have costochondritis, what is known as TEAD syndrome, where young females or young adults would have pain at the junction of the costal cartilage and the rib, and there's a local tenderness, which is the most important component of the diagnosis. Local tenderness at the junction of cartilage and the bone in the ribs. Then sternoclavicular arthritis and some rheumatic diseases and osteoarthritis of the cervical spondylosis can cause this, and rib fracture also. Then psychogenic or neurogenic causes, where most important is anxiety disorder. Many times, patients would come and say that they have chest pain, especially students going to exam, or there is some other stress in the family. The patient would come and complain of this also. And then we have neurogenic causes. Herpes zoster is a huge big misquender, because many a times, even all of us are fooled. Patient comes and says, I have severe pain in the left chest, and you start thinking of acute myocardial infarction and other things. And lo and behold, after 1 or 2 days, a rash appears, and we all know that it was nothing but a herpes zoster occurring in this patient. Similarly, neuropathic pain starting from the cervical ribs, cervical vertebra, or thoracic outlet syndrome, prolapsed cervical disc also can give rise to chest pain. So the challenge is to differentiate chest pain of cardiac origin, which is, as I told you, life-threatening, can be life-threatening and sinister, from non-cardiac origin of this chest pain. And this has to be differentiated reliably so that appropriate treatment can be initiated before any catastrophe occurs, right? So that is the importance of the talk today, that we are going to discuss this topic, chest pain. So the second sphere of talk would be GI diseases, like GERD and others. So these are some of the figures from a study done by 74 general practitioners, where about 1,212 patients were taken up with chest pain, and the cause of chest pain was analyzed in these patients. So patients who had GI diseases, and especially those with GERD, were analyzed, and they found that the majority of patients had retrosternal discomfort or pain. You see, the pain localization in many of the patients of GI disorders as well as GERD was in the retrosternal area. Of course, epigastric pain was left. It could be in the right or left chest also. The frequency, this is something very important, that we need to distinguish between cardiac and the non-cardiac pain, you see, because non-cardiac pain, which is originating from the GI tract, is a recurrent type of a problem, and the frequency of this pain is usually more than once per day. And that, of course, what is defines GERD also. And if you have epigastric or retrosternal burning for more than 2 times in a week, you see, then you call that condition as GERD, you see. So that is what defines GERD also. And then again, the character of the pain, though we all expect that pain arising from the GI tract would be of the burning nature, but no, it is not so. Good majority of patients would also complain of pain as a pressing type of a pain, a stinging type of a pain, or a dull ache. But remember, in acute coronary syndrome, which I said includes unstable angina, ST elevation, and non-ST elevation MI, the pain is usually always a pressure type of a pain. And patient complains that he is having a feeling that somebody is sitting on his chest and he's not able to breathe. So this is something very important. And I always tell my residents that if somebody comes howling into the emergency department or into your clinic saying कि डॉक्टर साहब बचा लीजिए मेरे को बहुत जोर से दर्द हो गया, remember he is not having any coronary syndrome. You see, because once if somebody has a acute coronary syndrome, the patient will not be able to speak loudly. He will talk in whispers and he'll hardly be able to breathe properly, and will say that he is having a very unusual feeling of his chest being compressed and he's not even able to breathe properly. So somebody who shouts or howls, you are sure that he's not, he's something other than a acute coronary syndrome. Now, these are some of the clinical indicators which put your diagnosis of chest pain as arising from GI tract than from coronary artery disease. The ones which are useful for including this as a GI disease would be pain which is worse with food intake. There could be associated vomiting and retrosternal pain. And especially in GERD, there could be pain worse after food intake, and there is a retrosternal pain radiation. Whereas if the pain is aggravated by exercise, or it is worse with breathing or with movement, you see. So any pain which is aggravated on exercise, you know, it is a cardiac pain. Any pain which becomes worse with breathing is usually a pleural pain, which could be either pleuritis or pulmonary embolism. And pain which increases with movement of the chest wall is mostly a musculoskeletal disorder, which can occur either with myalgia or with costochondritis. And if there's a localized muscle tenderness, you see that almost always rules out a cardiac origin of this chest pain. Okay, so these are some of the very important points that will differentiate between a cardiac and a non-cardiac pain. Now we go on to differentiating the chest pain of cardiac origin versus the so-called heartburn of the GI disorders. And as you see here, the heartburn which is associated with gastrointestinal disorders, the symptoms occur when you are bending over, lifting an object, lying down, or after meals. That this is the most important component. They usually are related to the meals that you have taken. And there is a sensation of acid backing up into your throat or a water brash. And then there is a stomach fullness with upper abdominal pain and nausea. There could be burping, floating, and flatulence. So these all will tell you that this retrosternal discomfort or burning is most probably a GI origin complaint. Whereas during the heart attack, the pain or discomfort is mostly retrosternal. It's not on the left side as most of our movies would show us. It is usually retrosternal, but the pain radiates to arms, back, neck, jaw, or stomach. So anywhere between lower jaw and epigastrium, the pain can radiate. This is not the case with a pain of GI origin. It doesn't radiate like this. And the second most important point, which you should always keep in mind, is breathlessness. You see, many times, especially in older people, females, and in diabetic patients where there's already autonomic neuropathy, there may be no chest pain at all. And the patient would just come to you saying that I have a very unusual feeling of discomfort with shortness of breath. So a very important, after this pain or burning, the most important symptom in acute coronary syndrome is shortness of breath, which is never seen in a patient of GERD. Okay. This may or may not be associated with sweating, with lightheadedness, nausea, or even vomiting. But yes, breathlessness becomes very important in patients who are older age group and patients who have advanced diabetes. So, and there is a gender differentiation also of chest pain of coronary heart disease. As far as risk factors are concerned, in males, smoking has a big correlation, which doesn't hold true so in females. Of course, in pains, in females, the pain is usually of a longer duration as compared to males. But as far as distribution is also concerned, the males would have more retrosternal chest pain, whereas in females, it is radiation of the pain which is more important. And similarly, breathlessness or shortness of breath is much more common in males than it is in females, whereas in females, extreme fatigue, lightheadedness are the symptoms which commonly they present with, and maybe even the upper GI symptoms. Whereas in males, it is a classical retrosternal pain associated with cold sweats and breathlessness. Okay, so there could be some gender differences in the pain of coronary artery disease. So, gastroesophageal reflux, which is part of GERD, I would say, is common in patients with coronary artery disease and may be increased by drug therapy also. I'll just be coming and telling you what are the drugs that we use for coronary artery disease which can give rise to gastroesophageal reflux. It sometimes may be associated with myocardial ischemia, but this is usually uncommonly symptomatic. But if it is there, then you have to differentiate, and this is a very common condition in our hospitalized patients. You see, whenever somebody with acute MI is recovering in the hospital, any chest pain for them is a recurrence of myocardial ischemia. But then you would know that it is not that easy to get a repeat infarction so soon, though it can happen. And you have to differentiate this gastroesophageal reflux in these patients from an actual coronary event. So, gastroesophageal reflux should be considered in the evaluation of patient with persistent chest pain, despite seemingly adequate antianal treatment. And you have to reassure the patient that the worst is over, and this is nothing but a gastroesophageal reflux disease that the patient is having whenever they have chest pain after recovering from acute MI. And as already I have emphasized that the GI origin of chest pain, where there is a heartburn, it may get worse after eating and lying down. It can be relieved by medicines. And this is what we do with our patients of GERD. I'll talk about that in a short while. A 2-week drug trial of proton pump inhibitors, where it easily differentiates between GERD and pain of ischemic origin. The pain and discomfort can be relieved by medicine, as I said. And acid reflux doesn't cause breathlessness, but it causes belching, burping, and bloating. Whereas heart attack does not cause these symptoms, but causes breathlessness. As I told you, after chest pain, it is the breathlessness which clinches the diagnosis of acute coronary syndrome, right? So, as I already told you that in females, the symptoms may be slightly different, and in females, they may have more of abdominal pain, and they may have pain in the arms rather than have retrosternal pain. But you should always remember that heart attack is a medical emergency. It doesn't give you much time. So you need to diagnose it immediately, as early as possible, so that treatment can be started without any catastrophe happening in these patients. So next we discuss about a little bit about acute myocardial infarction. How do we work up these patients, and what is the initial management of these patients? So this is a very, very important clue to differentiating again between chest pain of cardiac and non-cardiac origin. You ask the patient, do you often have heartburn? No, because anginal pain cannot be that frequent. Normally, it would come on exertion or after emotional outbreak, or after you see there is unusual exertion or emotional upset, and it will not keep on recurring so often as the heartburn might be. Every time the patient has food, he will say, "I am having some heartburn." So this complaint itself, a recurrent heartburn, has a sensitivity of detecting OD in 34% of patients and a specificity of 93%. The use of PPI test, as I was elucidating earlier, that you give PPIs, proton pump inhibitors, like pantoprazole, as a first diagnostic tool in patients with non-cardiac chest pain. And if they show relief, then you know it was this. But then this can happen only in patients who have angina pectoris. In acute MI, it doesn't give you time. You need to diagnose them faster. And this is one of the flow diagrams which suggests how do you evaluate chest pain. If it is a typical anginal pain, so all chest pains, we especially retrosternal pains or discomforts or even left-sided pain, we divide them as typical angina pectoris. And I hope you know about the Levine sign. You see, patient puts a fist on his own fist on the chest, in the center of the chest, describing his chest pain. So if that is happening, it is a typical angina pectoris. But if the pain is little here and there, he's not able to define it well, then it is called a atypical chest pain. So your initial complaint has to be the complaint of the patient has to be registered as atypical chest pain or typical chest pain. So if it is a typical chest pain, then you have to do a full cardiac workup, and if it is negative, then only you do a esophageal workup. But if it is a atypical chest pain and the symptoms are suggestive of esophageal disease, you may do some non-invasive cardiac workup because that may be coexistent also. So maybe a ECG or a echo can be done, or a lab test can be done, but then esophageal workup becomes very important. If the patient's symptoms are suggestive of cardiac disease, you first do a full cardiac workup, and if it is not positive, then you do a esophageal workup. And esophageal workup will include barium esophagogram, which is known as a barium swallow earlier, a flexible endoscopy, esophageal endoscopy, which through which you can see what is happening inside the esophagus, and a Bernstein test, which basically is a test to measure the pH of a mild, very mild acidic solution passed through a Riles tube in the patients, and seeing if they have their symptoms recurring when such a solution is passed through a Riles tube into their esophagus, or you can do esophageal manometry. So these investigations will tell you whether the patient is having what is known as GERD or reflux esophagitis. Now, to aid the diagnosis of a major cardiac event, as we have been telling you again and again that this is a this is a medical emergency. Some people have made some heart scores to diagnose these patients by giving different points to different parameters. And this is used in patients who are more than 20 years old and presenting with symptoms suggestive of acute coronary syndrome. You see, we first score their parameters like age and symptoms, EKG changes, and enzyme changes, and then divide those, the points earned are divided into three groups. 0 to 3 points means the risk of MAGE is only about 1%. So very low chance of the patient having a acute coronary syndrome. And if it is between 3 and 6, then it is a moderate chance. More than that would be a most likely diagnosis of acute coronary syndrome. So these are the various features that we look for. First, of course, the history. If it is only slightly suspicious, you're given 0 mark. If it is moderately suspicious, you're given 1 mark. And if it is very highly suspicious, means the patient says that I was going up the stairs, lifting some weight, and suddenly I had a retrosternal chest pain, which is making my breathing difficult. I have a little sweating. Then this is very, very highly suspicious, and the patient is given +2 marks. Then you do a EKG. Again, if it is normal, then you give 0 marks. But if there are non-specific repolarization disturbance, would mean any change in the ST. But if there is a significant ST elevation, which is more than 1 millimeters in more than one contiguous leads, you see, that's very important. You need to have it in more than one adjacent leads, and the ST elevation with convexity upwards, sorry, is a significant ST elevation, which would indicate acute myocardial infarction. Then age, again, if it is more than less than 45, you get 0 marks for this. 45 to 64 is 1, and 65 and above is 2 marks. Risk factors, if there are no risk factors, so there are various risk factors for developing a ischemic heart disease, which are nothing but markers of atherosclerosis. These includes hypertension, hypercholesterolemia, diabetes mellitus, obesity, smoking, and like this. So if these factors are present, if there are no risk factors, 0. If you have 1 to 2 risk factors, you get +1. And if there are more than 3 or equal to 3 risk factors, then you get +2 marks. And similarly, you do a initial troponin level. So remember, for acute MI, you will need to use three major criteria. First is the history. Of course, the age of the patient becomes part of the history. Then you have to do EKG, and then you have to do testing for the enzymes. We'll talk a little bit about the enzymes also. And we normally in the hospital setting, we do what is known as trop T or trop I test. If it is within normal, it is the marks are 0. If it is 1 to 3 times the normal, it is +1. And if the enzyme levels are more than 3 times, then you give +2 marks. You see, the minor pitfall in this grading or scoring for heart score is that you need to be expert in taking a history and in evaluating the ECG of this patient, because age would be known, risk factors would be known, troponin will be told by the laboratory or the hospital staff, but then you need to analyze the history and also the ECG findings. Now, there is another Marburg heart score, which has been validated, and it is a valid instrument for ruling out coronary artery disease. What is this Marburg heart score? These are the various features where you assign 1 point each for um, females more than 65 years or males more than 55 years. There is a known clinical vascular disease. The patient already has another vascular disease like hypertension or uh, previous ischemia. Patient assumes cardiac origin of the pain. The patient says it looks like coming from the heart, is worse with exercise, and it is not reproduced by palpation, which would be a musculoskeletal cause of the chest pain. So, 0 to 2 points intermediate risk, 1 point is mm, no, 0 to 2 is low risk, 3 points intermediate risk, and 4 to 5 points are high risk. So again, if you have a cutoff of 3 or more, then you know that there is a high chance of this pain being of cardiac origin, right? So we discussed something about the red flag signs, no? So any patient who walks into your clinic or to the emergency department, I again tell my residents that the most we talked about the symptoms, no? It has to be retrosternal after exertion in an elderly male or a female, maybe on a cold night, carrying heavy weights, uh, associated with the breathlessness and a feeling of tightness in the chest. And when you start examining these patients, very important the vital signs. You see, any change in their heart rate or pulse rate and any change in their blood pressure, you see, it always signifies that there is a coronary artery disease. So, coronary disease in 90% of the patients would cause some amount of either bradycardia or tachycardia, similarly, hypotension or sometimes even hypertension. So, if there is no cardiac changes in the vital signs as far as heart is concerned, you cannot be sure about it being ischemic heart disease. And similarly, the signs of hypoperfusion, whenever the cardiac output goes down after an acute ischemic event in the form of confusion, ashen color, diaphoresis. Again, very important indicator that is coming from the heart rather than from GIT. And this cannot be re-emphasized. Shortness of breath, I told you, sometimes may be the only symptom of patients of ischemic heart disease. Then hypoxemia on pulse oximetry, asymmetric breath sounds or pulses, new heart murmurs, and pulsus paradoxus, which would mean more than 10 millimeters fall of blood pressure during inspiration by the patient, which of course is not a very common finding in these patients, unless it is a massive MI or there is a pericardial tamponade that you will see this. But yes, very important out of these red flag signs, I would say signs would be some change in pulse rate and blood pressure. So if you see these two things, your suspicion grows that this is the ischemic heart disease. And this is what happens. Patients who have coronary artery disease are given drugs like calcium channel blockers, warfarin, statins, ACE inhibitors, nitrates. They all can lead to reflux esophageal disorder, and they may have chest pain because of this also, which needs to be considered in these patients very carefully. Oh,
Hello.
Hello.
Yes, sir.
There is something wrong with the slides. Can you see the slides? I can't see my slides
Yes,
here.
yes, yes, yes.
You're seeing the slides?
Yes, yes, we could.
I can't see it on my screen. Apart from a physical history and physical examination, uh, I must add that previously we used to use three criteria for diagnosing acute MI. One was the history of the patient, second was the ECG, and the third was enzymes. Now, out of these, ECG, all of you know that the sign of acute MI is ST elevation. Now, this ST elevation has to be present for more than 1 millimeters and in more than one adjacent leads. And various leads will reflect acute myocardial infarction in various areas of the heart. If it is in the chest leads, say V1, V2, or the limb leads L1 and AVL, it would no 1 AVL and V5, V6 would be a lateral wall. If it is in V1, 2, it will be septal. If it is V3 and 4, it will be anterior wall. So the leads in which ST elevation occurs will tell you where the acute MI is occurring. And this ST elevation can also be seen in some other conditions, like in premenstrual angina. You can have ST elevation. You can have ST elevation in acute pericarditis, but there it will be concavity upwards in majority of the leads, and it could also be seen uh, in what is known as a repolarization variant. You see, there also it may be seen, but it will be persistent. So patient would continue to have ST elevation.
Problem, speaker has dropped off. He will join uh, in short time. So meanwhile, what I will request you is that there is a survey which you can see on your screen for which is basically feedback for this webinar. So you can meanwhile go through the feedback survey and try to provide us the answer for feedback, which this will definitely help us for the future webinars. So yeah, so I
Okay.
will
Okay.
yeah.
So this is one of the slides showing the EKG of a patient who's had a acute enteroseptal MI. If you can see very carefully, starting from lead V1, where we can see very tall R wave. In lead 2, there is already a ST elevation, which is so in lead 3 and lead 4 and lead 5 also. You see, this is the first change that occurs during acute MI. This is followed by the appearance of Q wave, which has already started appearing. If you see from lead 1 to lead 4 at least, the Q wave appears, and then finally the T wave starts inverting. So if you have these three findings of ST elevation, a Q wave, and a T wave inversion, you are sure that this is acute MI. Next. So another thing that I would like to tell about the ECG is that whenever a patient comes and you do a ECG, many of times the patient has a normal ECG at the presentation. It's always a very good practice to wait for another 3 to 4 hours, repeat your ECG, and see if your changes appear in about 3 to 4 hours time. So that is something which is very important, that you do another ECG after 3 to 4 hours of the initial ECG and see if it can show some changes. It is working now. I am already there. I think I can do it like this also. You want me to go back to the laptop or should I continue like this?
No, you can continue, sir. We will continue.
Okay. Thank you. So that's about the ECG changes. Then when we talk about laboratory work of this patient, as I told you that we do certain enzymes, I have already told you about this. The CPKMB is the most specific enzyme that gets risen in acute MI. The only thing is it rises only after 6 to 12 hours, reaches a peak in about 24 hours time, but comes down in about 3 days time. So the importance is not for early diagnosis, but importance of CPKMB is one, that is more specific, and second, that in the course of the hospital stay of the patient, if the patient gets chest pain again, then this is the enzyme that we need to do, not trop T or trop I next, because if you see carefully, trop T and trop I, they remain elevated for 5 to 7 days, and trop T in fact for 10 to 14 days. So within 1 week's time, the patient gets chest pain again, you need to do CPK MB rather than do trop T or trop I. As far as myoglobin is concerned, as I told you, it is the one which rises the first, but it is very non-specific. Giving injections and doing some chest massage itself can give rise to increased myoglobin. So very non-specific, but yes, raises the suspicion, done very fast in the course of the presentation. Next. And add to this, before I talk about early management, now the fourth criteria, first is history, second is ECG, third is enzymes, fourth is ultrasound, echo examination. If you do a 2D echo, you have facilities of that. You may not have it in your clinic, but in an emergency department, if you have a echo, and you can show some regional wall motion abnormality, which will highly significantly tell you that this patient is having ischemic heart disease, right? Then about early management. Now, this is again something that everybody must know. What all we can do, even at the clinic level, is to first have a high suspicion of this being ischemic heart disease. Do a ECG, and if you find this ECG changes, so at least two criteria have been fulfilled. Immediately give aspirin to the patient. Even in normal dispirin, half a tablet can be crushed and put under the tongue to be or chewed, and this may be followed by clopidogrel also, and then give
Sorry
oxygen.
to interrupt,
Yeah.
sir. Yogesh here. Sir, there is a hand, I guess, in front of mobile camera, or some object is there in front of mobile camera, so we can't see you.
Is it there now?
Yeah, can you hold it from behind, sir? If it is possible.
I'm not holding it.
Oh, there is some object which we can see in front of camera.
Yeah.
Okay, sir, you can continue, sir. Yeah.
Is it still there?
Yes, sir.
Is it still there?
Yes, you can continue, sir. I guess, but.
So early management of these patients would include aspirin, sorbitate, which is isosorbide dinitrate, and then giving oxygen in case the patient has hypoxemia. You may not give oxygen if the patient oxygen saturation is okay. And most importantly, if you have morphine, which you may not have at the clinic, but in the hospitals, 3 milligram IV bolus dose may be given and repeated till the chest pain is relieved. Next. So these are some of the goal-directed therapies in patients after acute MI. 4 drugs which need to be given to all patients of acute coronary syndrome. You see, everybody must remember that every patient who has, in fact, angina or acute coronary syndrome must receive beta blocker within 24 hours, must receive a ACE inhibitor within 24 hours, must receive a statin, and in case there is any element of failure, he should also be given spironolactone or aldosterone antagonist or eplerenone, which goes a long way in treating their congestive heart failure. But these 3 drugs, beta blockers, ACE inhibitors, statins, along with aspirin, which is antiplatelet, and clopidogrel, must be given to all patients with acute coronary syndrome. Next. So now we talk about a little bit about GERD. You see, as I told you, any retrosternal burning which is related to the meals occurs more than 2 times in a week would tell you that this is a gastroesophageal reflux disease. You see, and the treatment goals for GERD patients is to eliminate symptoms, heal esophagitis, manage or prevent complications, because once this GERD occurs, there is a gastroesophageal reflux of the acid contents of the stomach into the esophagus. This may be because of a patulous G junction or because of hiatus hernia, you see, and there are a lot of risk factors which we will talk in a little while. They need to be addressed. And then once the patient has gone into remission, you need to maintain that remission. So the treatment for these patients could be non-pharmacological, pharmacological, it could be endoscopic and surgical. So we talk about non-pharmacological, there are a lot of risk factors for these patients. One is the change in dietary habits. So it is known to occur more commonly in patients who take a lot of chocolates and coffee, who have spicy food, who take highly acidic foods or fatty foods. So you need to avoid this. In addition to this, you need to avoid alcohol and tobacco, because these two things directly correlate with the uh, incidence of GERD. Then what you can do is lifestyle modification in the form of eating your food at least 2 to 3 hours before your bedtime, elevating the head end of the patient, lying on the left side, and wearing loosely fitted garments. One of the most important modification is to lose weight. And next, it is said that even if you lose a very small, as much as 5%, is it, will lead to a 40% reduction in symptoms of GERD. So weight loss we have a lot of data on this, that obesity leads to GERD and losing your weight tends to improve your symptoms of GERD. Next. Now, as far as pharmacological intervention is concerned, you see, patients who have persistent GERD symptoms despite dietary and lifestyle modification, you need to give them some medications and PPI score over all other drugs when it comes to treating these patients. So proton pump inhibitors, which proton pump, as all of you know, is the final common pathway of acid secretion into the lumen of the stomach. You see, you have three different pathways which will increase the which will stimulate the this cells, parietal cells, to cause acid release, which is either gastrin mediated or cholinergic mediated or through H2 receptors. You see, but the final common pathway is proton pump. So if you can inhibit this proton pump, you reduce the acid of the stomach and then relieve the symptoms of this patient. So you can either use proton pump inhibitors alone, you can use them with prokinetics like domperidone, you can use antacids, and now you have surface acting agents like alginates, which will again form a layer on the top of the stomach contents and prevent reflux. And you can also use histamine receptor antagonists, although of late there's been a lot of talk against the use of these drugs. Now, comparing PPIs. No, PPIs are the drugs which were introduced in 80s, and the first drug to be introduced was omeprazole. Later on, we had a lot of these drugs, and you would know that we have esomeprazole, lansoprazole, reviprazole, and then pantoprazole. If you ask me which is the best PPI, a very difficult question to answer. They all have almost equal activity with some minor differences between them. You can use any one of them. We normally don't give them with meals because meals would prevent their active formation and they take little time to work. So you need to give them before meals. But when it comes to pantoprazole, it has an advantage because it has minimal interaction with cytochrome P450. What does this mean? That many of the drugs that we use even during post ischemic cardiac ischemic event are the drugs which are metabolized by cytochrome P450, and clopidogrel is one of them. So if you use any other PPI in these patients for their GERD symptoms, there may be a difference in the pharmacokinetic of the drugs. So pantoprazole is one molecule which does not have interaction with cytochrome 450 and hence does not cause any drug interaction with other drugs being used in patients in post-coronary phase. So it is, if this is a basic dictum, that if you are using a lot of other drugs for the treatment of the patient and you have to choose a PPI, it's always better to use pantoprazole than use other drugs. As far as efficacy is concerned, I would say all of them are almost same, right? Of course, long-term efficacy is again something that is debated, and the long-term side effects are debated. But yes, if we have to use PPI in a patient on whom you are already giving a lot of anti-diabetics, antidepressants, anti-ischemic drugs, it is always safe to use pantoprazole. Thank you so much. I am sorry for the glitches, but I hope that something has been conveyed to the audience. And if there are any questions, I'll be glad to answer them. Thank you.
Thanks a lot, sir, for such a lucid presentation. Once again, apologies for the technical glitches what we went through. But I must say the audience was a very enthusiastic audience, and what we got is that more than almost 200 questions for this webinar. So that itself speaks that audience was attentive, and there are many questions which have come from their side. So, as you already highlighted in the initial part, that heartburn may not specifically present as a burning sensation only. So, it can be a pressure feeling inside the chest. That can also be one of the clinical presentation of heartburn itself. That will again cause a confusion, or that will again mimic the heart attack condition. Plus, you also highlighted that simple question, that how often you get the heartburn. That itself has a very good sensitivity, around 93%, to differentiate it from the cardiac origin chest pain. Plus, you also given us a tools like heart score, which can be easily mapped in the clinic, and patient can be differentiated based on the simple heart score. May not be requiring going ahead with the further cardiac workup. Then you finally highlighted about the initial management of heart attack patients, and also you thrown light on the GERD patient and their management, and throw more light on the PPI and their comparison. So that was a very good talk, sir. Now coming to the questions from the audience. So the one question which I can see that commonly getting repeated is that, what do you mean by silent heart attack? Can you throw more light on what does silent heart attack mean, and how we can manage or anticipate this condition in our clinical practice, or in the real life?
Right. Now, this ischemic heart disease is a huge big paradox. You see, if you go on evaluating the coronary arteries of, say, 100 people without any symptoms, you will find that a big chunk, say maybe 20 to 30% of them, will have critical heart disease, critical narrowing. So the symptoms in ischemic heart disease and the diagnosis, they don't match. You see, so many a times patient would have ischemic heart disease without chest pain. And this becomes all the more important in patients, in older patients, as I told you in my talk, or in patients who have long-standing diabetes, because they have some amount of autonomic neuropathy. So they won't have chest pain as their symptom. Even if they have a critical stenosis in the coronary arteries, they would come to you with a feeling of impending doom. They'll come with a feeling of breathlessness, which I have been repeatedly stressing on, and they will come with features of, say, sweating and diaphoresis and weakness, profound weakness. So this is what is a silent MI. The patient has acute MI, but he doesn't present with chest pain. So you need to look at these patients. Again, I re-emphasize that you look at their vital signs. Any change in their pulse or any blood pressure should lead you to further investigate and do at least the ECG in your clinic, and see if you can pick up these patients who have the so-called silent MI, where chest pain is not the predominant symptom of these patients.
Right. So basically, if patient is high risk and complaining of vague symptoms, it is better to get evaluated for if there is any underlying heart condition which is there.
Right.
In investigations, you highlighted about ECG and what are the changes which are happening. You also spoke about the 2D echo. So there is one question related to it. So what is the significance of this treadmill test and 2D echo in evaluating cardiac patients?
See, as far as acute management is concerned, as I told you previously, we used to have three criteria. You see, history of the patient, ECG changes, and enzyme changes. But now the fourth criteria for diagnosis of acute ischemic event or acute coronary syndrome has been added, which is doing a 2D echo. So this 2D echo tells you if there is a regional wall motion abnormality, which indirectly means that some part of the heart is not receiving blood supply and it is not moving with the rest of the heart during contraction. So if there is a regional wall motion abnormality, it very highly suggests that there is a ongoing ischemia going on. This is in the acute stress setting. But in patients who have stable angina or attacks of unstable angina, where you do a echo to find out again certain changes in the echo, or you do what is known as stress test. Now, this stress test again can be of two types. Either you evaluate them by doing their ECG during exercise, or evaluate them by doing their echo during exercise. So, in the ECG, if you find that there are certain changes of blood pressure, the changes of ischemia like ST depression, or sometimes even elevation, or some fresh changes occur in the T waves, they will indicate that there is a ischemia, underlying ischemia, though at rest, this patient may not have any ECG changes. Similarly, you do stress echo also. Patients who can do a treadmill will be made to exercise. Patients who cannot do can be given injection dobutamine, which increases the heart rate. Our purpose is to increase the heart rate, push the heart into stress, and see how the heart behaves during stress. So during exercise or during after dopamine injection, if the patient shows changes in the ejection fraction, changes in the contraction of the heart, then you would know that patient is having underlying ischemia, though at rest, both ECG and echo were normal, right?
Right,
So
right,
both in chronic setting as well as in acute setting, this is important.
right, sir, right. So thank you for your answer. And so there is one interesting question which I could able to see in the list. Is there any relation between erectile dysfunction and heart attack?
Erectile dysfunction, of course, indicates a long-standing
Resting.
autonomic neuropathy only, you see. So very commonly seen in diabetic patients, but indirectly, it again would indicate that patient has a long-standing diabetes, you see. So there is also a chance of having a atherosclerotic coronary artery disease. So, but I don't think there's a direct correlation, but they both indicate that there is advanced microvascular and macrovascular changes because of long-standing diabetes, that you can have them together. But there is no direct correlation as we have with, say, albuminuria and coronary artery disease or
Right,
retinopathy. So, but yes, they both would indicate that there is a chronicity of the condition and patient already has advanced atherosclerotic changes and neuropathic changes.
right, right, right. So thank you for your answer, sir. Now I am slowly moving towards GRD part. About the PPI. So there recently there are a few concerns about the long-term use of PPI. So what do you mean by long-term, and in your practice, how you know till what time you continue with the PPI, and are there any adverse events which physician should look after when patient is on PPI for long term?
No, when I keep on talking to my residents now, we talk about ultrasound. You see, ultrasound is one investigation which is advised by the patient, not by the doctor. So anytime patient has some abdominal complaint, on his own advice, he'll get a ultrasound. So holds true for PPI also. PPI is a drug which is prescribed by the patient, not by the doctor. We give the patient PPI for week 10 days, and he comes to me after 5 years and he says, Doctor साहब वो गोली खाए बगैर तो मेरी जिंदगी नहीं है. Every other day I have to take one dose of PPI to keep my GI healthy. So this is one problem, because somehow I don't know whether it is addicting or because it reduces the GI symptoms. Once you put the patient on a PPI, he continues to take it for years together. You see, initially there was big apprehension that if they are these PPIs used on a long time, because of nitrates not being reduced, they would cause malignancy. But over a period of time, we have found that one concern of long-term PPI use, normally they should be used for 2 weeks, I would say. And if you want to have symptom relief during remission, maybe another 4 weeks. So 4 to 6 weeks is the time that you should discontinue. In hospitalized patients, 2 weeks. If you want to give it for a little longer, not more than 4 to 6 weeks. But despite our telling the patients, they continue to take it for a long time. You see, and there's been apprehension about, first and foremost, is malignancy. But there is a paper published in 2022 in the American Journal of Oncology, where they have done a meta-analysis of about 1.2 million patients who've been on PPI for a long duration. I don't remember the duration, but more than 1 year or so. And they have found that there is a propensity of increased malignancy in these patients. You see, CA, stomach, esophagus, liver, and pancreas. These four, and paradoxically, they have found the incidence of CA breast goes down after using PPIs. So that's one thing, though it is very rare, but there is a chance that very long-term use of PPIs can lead to malignancies. And I'm quoting from a paper published in 2022 in the American Journal of Oncology. So that's one. Number two is nutritional deficiencies. You see, if the patient takes PPI for months and years, you may have deficiency of calcium, magnesium, you may have deficiency of iron and B12, though there are confounding reports that they may occur, but with iron and B12, we have seen this not happening, but with calcium and this thing, magnesium, it can occur. So is true for fractures. Long-term use of PPAs can lead to fractures. The exact cause is not known, but they say that osteoclast activation occurs somehow and fractures can occur. So this is another aspect. And another very interesting thing is about the change of gut flora. If you're using PPIs for a long time, the gut flora may change, and you may get what is known as spontaneous bacterial peritonitis, which is a common complication in patients of cirrhosis. You see, and can this is another concern that you need to look. So I always tell my patients that after 4 to 6 weeks, please don't use it on a regular basis. Use it only SOS. If you find your symptoms are not being controlled, don't use it as a chana or a mufli. You see, because it is so easily available over the counter. Everybody pops in one capsule of PPI and feels very comfortable. That's not correct. You may have drug interactions, you may have nutritional deficiencies. And this paper, as I was quoting, I mean, this is an eye opener for all of us, that we do not allow our patients to use them for a long time. Short term, 2 weeks, little longer, I would say 6 weeks. But beyond that, it has to be on a SOS basis. That is what my message would be. I think this is a controversial topic. Final word has to be said about this.
Right, sir. So as you perfectly highlighted that for initial phase, it should be used for short term. And if patient is of non-erosive, then on-demand use can be done. If patient is of erosive disease, then it may require long-term maintenance therapy to
Correct.
prevent.
You have to have a definite indication for using it on a long-term basis.
Definitely.
It cannot be used just for so-called indigestion or dyspepsia.
Yeah, so very long-term use definitely has some pros and cons associated with it. There is one more question about, is there a difference between heartburn, or I will say GERD, and gastritis, and how to differentiate it, with these two conditions?
No, as we talked about GERD, GERD basically is gastroesophageal reflux disease. When the contents of the stomach, normally they should not go back to the esophagus. But if the gastroesophageal sphincter becomes lax, or a condition called hiatus hernia, so in these situations, the acid content of the stomach may go into the stomach. And once it goes into the stomach, it can lead to 3 or 4 complications. One, it may not cause any symptom at all. There is a reflux, but no symptoms. Or you may have esophagitis, where you have uterine burning. You may have what is known as Barrett syndrome as a complication, where the mucosal lining becomes different, and it is a pre-malignant condition. Or you may have esophageal strictures. This is GERD. You see, where you have retrosternal burning occurring more than twice in a week. So that is reflux of contents of stomach into the esophagus. Whereas gastritis is when there is inflammation in the stomach because of increased amount of acid. So there the pain will be mostly confined to the epigastrium. It will be more related to meals. And of course, you may not use prokinetics in this situation. But when it comes to GERD, the pain will be mostly retrosternal. Again, will occur little later in the after meals, and you will require some prokinetic also to relieve the pain. So they, of course, the basic cause is same, but mechanism is different in two conditions. So gastritis is in the stomach, whereas GERD is in the esophagus.
Right, sir. Right. So basically, as you highlighted, that gastritis is basically where stomach is at suffering,
Fault.
while GERD is basically esophagus, which gets mainly affected because
Correct.
of acid reflux. So
Correct.
there,
Correct.
I will be taking just last two questions. One common questions which is coming up is about the dietary and the lifestyle modifications for cardiac patients. So what are the common recommendations from your side? So what you recommend to the patients commonly? So that's what the audience wants to know.
No, dietary recommendations, everybody knows that obesity is not good. So you need to reduce your weight, keep it within the range of 18 to 25 BMI. That's something very important. And for this, you need to cut down on your fats. In any case, cholesterol, as they say, lower the better. So you need to reduce your solid fat intake, whether it is makhan malai or ghee, all things have to be go down. And as when obesity is concerned, then even your oils also are culprit. So you need to cut down on this. If you're hypertensive, you need to cut down your salt, increase your potassium intake. You see, and it has been already said so many times that more frequent small meals are better than having heavy meals. Lunch should be a little heavier than the dinner. You see, and these things are carry a lot of weight. And when it comes to lifestyle modification, what we recommend is half an hour of brisk walking 6 days a week, which is the minimum that you should do. If you can do more than that, it's always welcome. And then, of course, no smoking. Alcohol has to be cut down. So some people say key in moderation, but then moderation and severity is a very thin line. So they must be restricted. Smoking is a big no. And of course, some people say high fiber diet, taking more potassium might help. So especially in patients of hypertension, you need to increase your potassium intake, reduce your salt intake. So these are the things that, and you need to relax, you see, and be less competitive in this modern world. You see, this is what is driving everybody to a lot of stress, this competition amongst people. So I think you need to relax, do some yoga or meditation. They all help.
Right. So basically, it's a tasty and what so-called pleasurable things you should stop. So that's
Right.
what the in a nutshell, that's what the message is. So last question from my side. You in last few slides you highlighted about the comparison of PPI, where you highlighted about the drug-drug interaction part as well. So now, if I ask you, if patient is elderly who is on multi-medication, so is there any preference towards any PPI from your side because of drug-drug interaction, or which one is the more preferred PPI in this type of patients?
You see, many times people ask me this also, which is the most preferred PPI. You see, so there is nothing called a better PPI than others. Of course, omeprazole was the first salt and it needs to be given empty stomach, but others also should preferably be given before stomach, and their efficacy seems to be almost equal. It depends on what PPI suits somebody else. Only thing is there is a concern about the pharmacokinetic of drugs. As I highlighted in my talk also, that once the patient is on multiple drugs, there could be drug-drug interaction, and especially when the PPIs will stimulate cytochrome P450 and may influence the metabolism of other drugs.
Right.
This is one situation where pantoprazole scores over others. It has the least drug-drug interaction. And so if your patient is on multiple drugs, it is always safer to use pantoprazole over other PPIs. But if you ask me about the efficacy, all the PPIs are almost same. And please, through this talk, I also want to send a message that if the patient is on PPI, don't use the H2 blockers in any case are out of getting out of work because of the side effects. But don't use a H2 blocker with PPI. PPI is a final common pathway of acid output. Once you are blocked, then rest of the things become insignificant. So please don't use H2 blockers along with PPIs, right? You can use antacids because they give a symptomatic relief, but not other H2 blockers with PPIs. So out of all the drugs, I would say pantoprazole scores over other as far as drug-drug interaction is concerned when it comes to polypharmacy. Yeah.
Right. So that was a very key point you highlighted, sir, that if patient is on PPI, where already a last path is getting blocked, there is no
Correct.
requirement of S2 receptor antagonist. You can give an antacid if patient has symptoms still if patient is, in spite of taking PPIs. And as we also highlighted, that pantoprazole is also has slightly edge over other PPIs, not from the efficacy point of view, they are all equal, but yes, from drug-drug interaction and CYP2C4 450 enzyme, as far as that drug-drug interaction part is concerned, pantoprazole has slight edge over the other PPIs. So with this, I would like to thank you, sir, from bottom of my heart for such a lucid talk and such a clear answers to the audience questions, for providing such a clear answers. And it was really privilege having you on this Sankalp webinar. And once again, thanks a lot from on behalf of Sun Pharma, sir. I would also like to thank our audience for being such a patient audience and such a enthusiastic audience, which poured the lots of questions, and that made interaction webinar in the end as a interactive session. And also, I would like to thank the backend team, without which this webinar would not have been possible. And once again, apologies for the technical glitches, because of which some wastage of time happened in between. But again, in the end, we could able to have a good interaction with our speaker. So thanks a lot, sir.
Thank you. Thank you.